All right, let's dive into a high-yield review of colorectal cancer. We're going to focus on the stuff you absolutely need to have locked down as a trainee, not just for your exams, but for when you're on the wards. Let's get right into it.
So first off, why is this so critical to know inside and out? Well, because colorectal cancer, or CRC, is the fourth most common cause of cancer deaths. This isn't some rare zebra diagnosis. You are absolutely going to encounter this in your career, so knowing the fundamentals is a must.
So, here's our game plan for this review. We're going to kick things off with the key hereditary syndromes you'll see, then we'll get into the nitty-gritty of staging, which is crucial, and we'll wrap up with the core principles of treatment. Okay, let's start with the genetics. When you hear hereditary colorectal cancer, one name should immediately pop into your head: Lynch syndrome. It's the most common of the bunch, and it's one you really need to be able to spot.
So, what exactly is Lynch syndrome? Well, at its heart, it's an inherited or germline mutation in the genes that are responsible for mismatch repair. You can think of these genes as the cell's spell checkers. When those spell checkers, like MLH1 or MSH2, are broken, DNA errors start to pile up, and that just skyrockets the risk for certain cancers.
Now these are the clinical clues, the little red flags that should make you think, could this be Lynch syndrome? While it's only about 3% of all cases, look at that mean age of diagnosis, 44. That is way younger than what we see for sporadic cancers. Also, the fact that 70% of these tumors pop up on the right side of the colon, that's a classic finding. And if you ever see synchronous tumors, meaning more than one primary cancer at the same time, your suspicion for Lynch should be through the roof.
And here's a super important point, and a classic exam question, by the way. Lynch is not just about the colon. You absolutely have to know the other cancers associated with it to take proper care of these patients. So what are they?
And wow, the numbers here are just striking. The lifetime risk for endometrial cancer can be as high as 60%. This is a huge deal. For women with Lynch syndrome, we have to be just as worried about endometrial cancer as we are about colon cancer. This changes everything. It means specific screening, it means conversations about risk-reducing surgery, and you can see the risks for ovarian and gastric cancers are also way up there, which is exactly why a detailed family history is so incredibly important.
Okay, let's switch gears. Once a cancer is diagnosed, what is the absolute most important next step? It's staging. We use the TNM system, and this is the universal language we use to determine prognosis and guide every single treatment decision we make.
You know, it's actually beautifully simple. T stands for the primary tumor. How deep has it burrowed into the wall of the colon? N stands for nodal metastasis. Has it escaped to any of the nearby lymph nodes? And M, of course, stands for distant metastases. Has the cancer traveled to other organs, like the liver or the lungs?
The whole staging process follows a pretty logical pathway. You start with the diagnosis from a colonoscopy and biopsy. Then we get a clinical stage based on imaging, usually a CT scan. But, and this is a critical point, the final, most accurate, pathologic stage only comes after surgery, when the pathologist can actually hold the tumor and lymph nodes and examine them under a microscope. And this right here is why that stage is so incredibly important. This slide tells the whole story. It connects that TNM stage directly to a patient's prognosis. I mean, look at the difference. A patient with stage 1 cancer has a 74% 5-year survival rate. But once that cancer has spread to distant organs, stage 4, that number just plummets to 8%. This is why we stage. It tells us and our patients what kind of fight we're in for.
Okay, let's talk treatment, and let's start with the earliest presentation. A really common clinical scenario is finding a malignant polyp, a polyp that has cancer cells inside it, and this creates a major decision point. Was just taking the polyp out enough, or does this patient need a full-blown colon resection? The answer really comes down to one key distinction.
So on the left, you have what's called carcinoma in situ. Here, the cancer cells are totally confined to that top layer, the mucosa. They haven't broken through the basement membrane, which means the risk of them spreading to lymph nodes is basically zero. A simple polypectomy is curative. Game over. But on the right, you have a true malignant polyp. This means the cancer has invaded deeper into the submucosa, and suddenly there's a 2 to 8% risk that cancer cells have already escaped to the lymph nodes. This changes everything, and now you have to have a serious conversation about a major surgery.
So if that malignant polyp does need more treatment, or if we're dealing with a more advanced but still localized cancer, the conversation turns to the mainstays of curative therapy. We're talking surgical resection and adjuvant therapy.
For colon cancer that hasn't spread all over the body, the goal is cure, and surgery is our primary weapon to get there. The surgeon goes in, removes the tumor along with a good chunk of the draining lymph nodes, and that's how we get that definitive pathologic stage we were just talking about.
But surgery isn't always the end of the story. Sometimes we need to give chemotherapy after the surgery to basically mop up any microscopic cancer cells that might have been left behind. We call this adjuvant chemotherapy. So the big question is, who needs it?
And the answer is driven entirely by that pathologic stage from the surgery. It's a definite yes for all stage 3 cancers. If there's any lymph node involvement, they get chemo, period. For stage 2, it's a bit more of a gray area. We give it for what we call high-risk stage 2 cases. This includes things like big T4 tumors that have grown all the way through the colon wall, or cancers that just look really aggressive under the microscope, or show signs of invading into blood vessels or nerves.
So look, if you take one thing away from all of this, let it be this. Staging is everything. It is the absolute king. It dictates the therapy, it predicts the prognosis, and it frames every single conversation you're going to have with your patients. From spotting the genetic risk in Lynch syndrome all the way to making the tough call on a malignant polyp, every single detail matters because it all feeds in to that all-important stage.
And that brings us to the future. So we'll leave you with this question to think about. As our understanding of tumor biology gets more and more sophisticated, with things like liquid biopsies and molecular subtyping, how are we going to integrate all this new information with the classic TNM staging we've just discussed? How will staging itself have to evolve to guide the next generation of truly personalized CRC treatments? Thanks for joining us.